thanks a lot again to the organizers, my colleagues from Linz, for organizing this amazing workshop. It is my great honor and pleasure to introduce the keynote speaker, Janet Currie. I mean, it is probably not necessary to introduce your academic achievements. Everyone here knows about her work. That's also the reason why you're all here, and we all are fans of your work. Janet is one of the leading economists of these times, and so it's a great pleasure to have you here. I just want to say some other things, because like I had also the pleasure to be at your home recently last year, because like I worked together with your husband Bentley, and before when Bentley invited me, I was actually pretty nervous, I have to say. I thought, oh man, like this. I mean, I knew Bentley before. I thought, oh my God, this distinguished star Janet is also there. But once I arrived there and met you for the first time, this nervousness totally disappeared, because like two of you were so nice, humble, welcoming, and really, really made me feel home. So that's what I learned here, that they're also like are super genuinely nice people. And why am I saying this? So it's like, of course, important that we have nice people in the profession, but because we all no. Wait a second. We all know, I mean, we're all aware of the discussions that we had in econ in the past month and years about the toxic environments, about power structures, about networks that are problematic. And we discussed this, and we thought about ways out of this, whether we should be optimistic or not about the future of our profession. And what we also learn in like more my field, organizational economics, that the characteristics of leaders of organizations are extremely important. And so since we now have like a great personality like Janet being one of our leaders, makes me actually quite optimistic also about the future of our profession. And that's why I'm not only happy that you're here, but also happy that you're like one of our leaders. And I'm really looking forward to your talk. Thanks a lot.
Well, thank you so much. That's the type of introduction that makes me nervous, because then you wonder whether you can possibly live up to the hype. So I just want to say I'm honored to be here. I'm also very honored by all the papers. A lot of them have referenced my work, and I feel like I'm almost coming at the end of the day summarizing in a way a lot of the great work that you have already presented. And I'll try and weave in some of the themes that we've already been talking about. So my theme for today is child health as an important form of human capital. And my starting point, actually, I was trained as a labor economist, and we learned a lot about human capital. And we learned that it was really one of the most successful ideas in modern economics. It captures two very important ideas. One is that a lot of society's wealth is embodied in people. So people are very important. And investments in human capital have concrete returns that you can measure. So it's not just a rhetorical thing to say that we should invest in children. It's something where you can actually see payoff along a lot of dimensions. So this research on human capital formation initially focused more on education and training by people like Gary Becker and Jacob Mintzer. But Grossman was the first to really treat health as an important dimension of human capital. And since that time, there's been a lot more work. Over the past 30 years, in particular, there's been increasing attention to child health as a particularly important form of human capital. So what I'm going to talk about in this lecture are some highlights from the recent literature. A lot of it will revolve around a kind of extended example of a policy intervention to extend child health insurance and its effects on both health and income inequality. And then I'm going to try and suggest some directions for future research, including a focus on mental health, which has already come up quite a few times in the discussion today. So to study child human capital, we need to make some tweaks to the basic conceptual framework that we inherited. In particular, you'd like to have a production function for child health that allows there to be different effects of investments, in at least 2 periods. So you want to have a different effect of investments in early childhood, which here is going to be period 1, and later in life. So this is a 2-period constant elasticity of substitution production function, where a bar over I1 indicates that you could think about the investment as already having occurred, and then deciding what's going to happen in period 2. Now, each investment is chosen, but there's also shocks that can occur in each period. Some of them that we've been discussing, like stress or pollution or child maltreatment. We have different weights on the 2 periods, and we have a productivity shifter, A. So you can think about different families maybe as having different levels of productivity. And then there's also an important parameter, phi, which measures the substitutability of investments in one period and another. So the parents then are assumed to choose what investments to make in order to maximize their utility, where their utility depends on the child's health, but also all the other consumption that they want to do. And they maximize subject, of course, to a budget constraint. So just some comments about this overall basic framework. The first is that families can differ in terms of all of these parameters: the productivity shifter, the weights that they put on early childhood compared to other periods, their tastes for investments in child health, the substitutability can be different, and also, of course, prices. And a lot of social programs could be thought of as affecting these decisions through their impacts on prices. So one implication is that you should expect to have different effects on different types of families. Another reason for that is because if you think about the usual concave production function, different people are starting at different points on that production function. And so depending where you start, the same increment is going to have a different effect. And then a third thing about this particular production function is, depending on the parameters, the effects of early life events don't necessarily have to depreciate, which was one of the characteristics of the initial model that Grossman came up with. So you had an early life shock, and basically people were assumed to get over it given enough time. Here, the effect of shocks could actually grow over time. So I think this is a very useful framework for thinking about the different pathways for investments to affect child health, or different parameters that might be affected by public policy. But I think Bettina showed us today how very difficult it is to actually estimate one of these production functions. You don't know the functional form. The functional form can drive certain results. You don't measure all the variables that you'd like to measure. There's measurement error in the ones that you do measure. And it just, in order, given the latest technology that we have, just in order to estimate this, you have to make a lot of simplifying assumptions. So for policy, most of the research takes a different approach, which is really more of a potential outcomes framework. And the idea here is to try and mimic an experiment that has treatments and controls. So most of the time, if we're looking into something that changes child birth weight or something like that, we're not going to run a social experiment, right? It's just not on the cards often to do that. And so then you have this problem that, well, we only see one outcome per child, and what we'd really like to see is the counterfactual. Well, what would have happened to that child in some counterfactual universe where whatever really did happen to them hadn't happened? So then the whole problem is to find a comparison controlled child whose outcomes are similar or arguably similar to those of the treated children. So I will try as I go through to talk a little bit about how different studies have approached that particular problem, but that's kind of the name of the game in most of this literature. Okay, so the policy intervention that I want to talk the most about today is an expansion of health insurance coverage as a particularly important example of investments in children. Now, the example that I'm going to talk about happened during the 80s and 90s in the United States. So it has nothing to do with Obamacare or any of the discussion of the most recent expansions of health insurance, which mostly affected adults. The reason why those mostly affected adults was because the children were already covered under these previous health insurance expansions. Because these happened relatively long ago, we can follow up to the present time and see what the long-term effects of these expansions were, as long as knowing what the short-term effects were. So this program that I'm going to talk about, Medicaid, is the largest US social program that affects women and children. I'm comparing it here to two other very large social programs. One is the Earned Income Tax Credit, which we heard a little bit about in the last presentation. The second one is used to be called food stamps. It's a nutrition program, also a large program. And then you see Medicaid, which just dwarfs these other things. And you also see that spending on the Medicaid program, and I should say, for these comparisons, I've tried to take out only the spending that affects women and children, not the spending on other groups like the disabled. So the spending really grew. And in this context, that's not really so much of a problem. It was actually intentional. So one reason why it grew a lot for women and children was because they expanded coverage. So why is coverage of pregnant women particularly important? This was the first group to get the expansion of coverage. Again, we've heard today about how the fetal period can be considered to be a critical period. This was first a medical literature, but it was sort of adopted by economists who then started looking at a wider range of both shocks and also outcomes. The types of shocks that are considered, pollution exposure, nutritional deficits, maternal stress, are large. But the really nice thing about this is that since the period in utero is small and very well defined, it's relatively easy to measure effects of things that happened in utero. An important point that I would like to make that comes out of this literature is that the sort of paradigm that we think about all the time, is it nature or is it nurture, is actually not a very good paradigm, because it's almost always both. It's both nature and nurture, and they interact. And so one small example of that, this is from a paper that I did with Enrico Moretti, where we linked birth records for, you can think of grandmothers, mothers, and babies. And then what we look at is the effect of mother's birth weight on child's birth weight. And here, this is just a graph where we have mother birth weight on the x-axis, child birth weight on the y-axis. And so you can see this is upward sloping. Mother birth weight and child birth weight are related. That's maybe not very surprising. But what's more surprising is that depending on where the mother lives at the time of the birth, you get higher child birth weight if she's living in a wealthier place than if she's living in a poorer place. So conditional on all of the things that we saw about the mother, like her education and where she was living at the time of her own birth and so on, we still see that where she's living at the time of the birth matters. So the environment interacts with the predetermined thing, which was her own birth weight, to produce higher or lower child birth weight. So this expansion of Medicaid coverage to pregnant women was very large. This is showing on average for the whole country that if you looked in 1979, a little over 10% of women were eligible for Medicaid coverage of their pregnancy and delivery. By 1993, over 40% of women were eligible. And still today, almost in many states, 50% of women's pregnancy and deliveries are paid for by the Medicaid program. So people always think of the United States as a place where health insurance is private and there isn't really any public health insurance, but that's kind of misleading because for a lot of groups, there is a lot of public coverage. Now, the way that this was phased in, because the United States is a federal system and states have a lot of power, especially over things like healthcare, the law said that eventually all the states would have to get to the same level in terms of coverage. But they started at very different places. So places that had very ungenerous coverage had to increase coverage a lot. Places that started with generous coverage increased it by a lot less. So this map, which is from a paper by Sarah Miller and Lara Weary, is looking at the change in the fraction of 18 to 44-year-old pregnant women who would be eligible for Medicaid coverage of their pregnancies if they became pregnant. So it's just trying to show that there's a lot of variation across places. So in some early work with John Gruber, we looked at the effect of these expansions and used this variation across states. And what we found was that there was an 8.5% reduction in infant mortality, and that we could trace that to changes in the use of medical care. So, for example, there was a 50% reduction in the fraction of poor mothers who delayed obtaining prenatal care beyond the first trimester of pregnancy. Okay, so, but as I mentioned, the really great thing about this is that since it happened a long time ago, we can look at these cohorts and see what their outcomes are now, that there's in their 20s and 30s. And so again, this is from a paper by Miller and Weary, where they assembled data from a lot of different surveys on different types of measures. So let me talk about these measures a little bit. I also want to point out, I'm doing this for two different groups, people who are poor and all mothers. Okay? So if we look at people that are poor, we see an improvement on this Kepler index. So this is an index of mental health. So this is suggesting that cohorts whose mothers were covered by Medicaid during pregnancy actually have better mental health in their 20s and 30s. We see a small decrease in the probability of using food stamps. We see a small increase in the probability of attending college, a somewhat larger increase in income, and then actually quite large falls in the number of hospital visits per 1,000 and in the number of chronic conditions that people are diagnosed with. And these changes are large enough that we also see them when we just look at the whole population. And again, I want to make a connection here, a little bit speculative, but if you look at this age group who are in their 20s and 30s, one of the main things that they get hospitalized for and the main chronic conditions that they're diagnosed with are actually mental health conditions. So this might be consistent with the general improvement in mental health. Okay, so that was for the pregnant women. After they covered the pregnant women, then they started covering children. And among the US children, there was a sharp cutoff in eligibility by birth date that can help us to identify the effects. So only children who were born after September 1, 1983 were eligible for this new health insurance coverage. People who were born on August 31st, 1983 were sort of permanently out of luck. And a lot of recent research has used that discontinuity to try and examine the effect of becoming eligible for health insurance coverage. You can see this was phased in as well. So the first group to be covered are the 0 to 3-year-olds. You can see the rate goes up from about 20% of kids being covered to 50% of kids being covered. In the 13 to 17-year-old groups, they don't start getting covered until later. And the rate here goes up from about 15% to over 40% being covered by the end of the phase-in period. So if we compare here on the left, cohorts who were born before this expansion of eligibility, the darkness of the color is showing how many years of Medicaid eligibility they would get on average in different states. And then you can see that the cohorts born afterwards, the map is generally much darker, so they're eligible for more years of Medicaid coverage. This is from a paper by Brown, Kowalski, and Lurie. Actually, it was published in 2022, so that needs to be fixed. So this health insurance expansion arguably reduced child mortality. We saw that there was an effect on infant mortality. And one way to see this effect on child mortality is to use this machinery that Joachim was talking about earlier this morning. And here I'm going to show you a comparison of the US and Canada. So Canada arguably is a good comparison for the US. There's a lot of similarities in terms of the general level of wealth, the types of medical technologies that are available, even things like the number of miles that people drive, which affects mortality through auto accidents. But a big difference is that Canada's had universal public health insurance since the 1970s, whereas the US had this expansion that I'm talking about and then didn't really do anything to cover more people until 2014. Okay, so to implement this kind of mortality comparison, we first ranked the counties from the richest to the poorest. We put the counties into groups that each represent about 5% of the population, and we look at them separately for different census years. In each census year, I'm going to compare mortality in different groups. You could think of, for example, comparing the people in the bottom 5% of the population and the people in the top 5% of the population. So this just shows a figure for one group, girls age 0 to 4. Along the x-axis here are poverty percentiles. So 0 here are the richest people, 100 are the poorest people. These lines generally slope upwards, which indicates that poorer people have higher mortality on average. And here the blue lines are for the US and the red lines are for Canada. The top lines are for 1990 and the bottom lines are for 2010. Okay, so looking at the blue lines first for the United States, you can see there was a big decline in mortality and that it's much bigger in the poorer places than in the richer places. Looking at the red lines, there's also a decline in mortality, but it's kind of the same in the rich places and the poor places. And also you can see that the line is much flatter in Canada than it was in the United States. So this gradient in mortality was much more pronounced for the small children. And over this 20-year period, with this introduction of health insurance, you see that these two lines become much closer together. Okay, so health insurance obviously isn't everything in terms of predicting mortality, but arguably it had a big effect closing this gap. If I look at all the groups together, so now it gets really crazy. Here there's 3 lines. So we have 1990, 2000, and then the most recent data that we had, which is either 2016 or 2018. You can see that in the 0 to 4 age group and the 5 to 19 age group, we have in the United States big declines in mortality over that whole period. The declines for prime age people who didn't have public health insurance are much smaller. And in fact, between 2000 and 2018, there's very little decline. And then if we look at older people, this group also has public health insurance. We again see these very large declines. So up until the Affordable Care Act, old people and children had public health insurance. They benefited from gaining insurance and from the technological changes in medicine. And the group in the middle really shows much less improvement, which has been the subject of a lot of discussion in the US. This is the same thing for males. Okay, so this Medicaid expansion, I would argue, reduced mortality and improved health among poor children. But when we talk about human capital as economists, we're often talking really about something that increases people's income. So you might ask, well, is there any evidence that this actually increased people's income? Even in the United States, availability of administrative data helps us to look at those kinds of questions by looking at the cohorts who were affected by the shocks in the prenatal period or early childhood. So this figure is from the paper by Brown, Kowalski, and Lurie that I mentioned earlier. And what they've done here is to use income tax data. And they've divided people up into 3 different cohorts, depending on whether their families were relatively poor, that is with incomes less than 200% of the federal poverty line, that's the black line. Whether they're sort of in a medium group, which is the brown line. And then the faintest line here is for families where the families were really quite well off. So the family had income over 500% of the federal poverty line. All of these lines have been normalized to be at 0 in age 19. So they're saying, okay, let's suppose the baseline here is 0, and then say how much more in taxes are you paying each year for each additional year of Medicaid eligibility during childhood. Okay, so the estimate here overall is suggesting that by age 28, people are paying $800 more in taxes per year of Medicaid eligibility. So that's a very large effect that pays back a lot of the cost of extending health insurance to these groups to begin with. Okay, so now I want to pivot a little bit and come back to this idea that mental health might be particularly important. And so one reason why I think that is because mental health is one of the most important determinants of adult outcomes, especially because it affects whether people are able to work. Mental health problems are also very prevalent. Worldwide, 1 billion people are estimated to live with some kind of mental health disorder. And this sort of connects with my research on children because 50% of mental disorders are estimated to start by age 14. The rest of them typically start in adolescence and young adulthood. So it's something that kind of disproportionately affects young people. It may affect them at particularly critical periods connected to their schooling, and then can cause lifelong disability. This is something that it's relatively new for economists to be talking about mental health, but we had our own euphemism for talking about this earlier, which was to talk about non-cognitive skills. And I just want to make the comparison here between things that are labeled often in economic research as non-cognitive skills and things that are labeled as mental health. So this is from a paper by Per-Anders Eden, Peter Fredriksson, and other co-authors looking at Swedish registry data and trying to measure the labor market returns to non-cognitive skills. They have data where all male draftees were tested and they were given tests that identified these particular types of skills. So the ones they focus on are social maturity, focus, internal motivation, and stress tolerance. And I just want to draw a line between each of those things and some common mental health conditions. So for example, if you had autism spectrum disorder, then you might be judged to lack social maturity. If you have ADHD, then you lack focus. If you are depressed, you may lack internal motivation. You know, if you don't want to get out of bed in the morning, that's sort of could be interpreted like that. And if you have an anxiety disorder, then you have a problem with stress tolerance. Okay, so you can think of these common mental health conditions as existing on a continuum and being quite similar to what economists call social skills in a lot of ongoing research. This is a figure from a famous paper by Heckman, Stixrud, and Zawa, which tried to estimate the relationship between cognitive skills, non-cognitive skills, and wages. So if you look at the edge of one of these figures, if you move along this edge, you're looking at improvements in cognitive skills. And if you look along this edge, you're looking at improvements in non-cognitive skills. The bluish colors are showing low wages and the red colors are showing high wages. And so, you know, the point of this is that if I have very bad non-cognitive skills, then even if my cognitive skills are really good, I still only have low wages. And similarly, if I move along this edge so that I have low cognitive skills, but better non-cognitive skills, and my wages improve, but they're still not very high. And the people who have the highest wages are the people who have both of these dimensions of skills, right? So we know this already. We know that there's lots of smart people who have other issues and so then don't do as well as maybe we think they should. Okay, so in addition to affecting wages, these mental problems can affect employment, as I said. So this is a figure that's taken from the Eurostat database, and it's just showing the difference in employment probabilities for people with depression and without depression. I picked depression as a particularly common mental health disorder, and I circled Austria here. You can see that there's a big difference in the probability of being employed at all, depending on whether people are diagnosed with depression. And if you look at something like the UK Labour Force Survey, which looks at days lost for different causes, you can see that mental health jumps out as something really important in explaining days lost. This is partly because if you lose days because of a mental health condition, you're likely to be out of work for a lot longer than if you lose days due to a lot of physical health conditions. Looking at physical health conditions, musculoskeletal things like lower back pain are really important, but they're dwarfed by mental health. And then you see everything else in the green bar. Okay, so this is quantitatively important in affecting your labor force and your ability to be in the labor force. As I mentioned, these mental health problems often begin in childhood, continuing into adulthood. And so in an attempt to just measure how important these things were, I used data from Canada where we could link data from health registries to data on welfare participation and also some educational data. And what we did was to compare the impact of some of the most common physical conditions affecting children, one of them being asthma, another one being injuries, to those of the most common mental health conditions in our data, which were ADHD and conduct disorders. And then we looked at the impact of having one of these conditions at 4 different age ranges, as well as looking at persistent conditions. So we had 50,000 children. This was from one Canadian province. And in order to try and identify effects, we compared children with the condition to siblings without the condition. Of course, we do a lot of checking to try and understand why one sibling would have a condition and the other sibling didn't. And the outcomes we look at are whether the child was on welfare after age 18, whether they were on time in school, measured by whether they were in grade 12 by age 17, and whether they were taking the courses that they needed to take in order to get into the public university, which is the only university in this province. Okay, so here what I'm doing is just plotting the coefficients on those models, and what stands out here, the outcome is being on social assistance after age 18. And you can see that having one of these mental health conditions has a large effect, particularly if you still have it at age 14 to 18. And it has much larger effects than this category, which is severe injuries or asthma. Similarly, if we look at the estimated effect on whether you're taking the math courses that you need to get into public university, you see a negative effect of the mental health conditions, which is much larger than the effect of having an injury or of having asthma. Okay, so we talked a little bit about the importance of covering women during pregnancy. One reason for that is that there seems to be a lot of evidence that prenatal conditions can place children at risk of poorer mental health. Some of the earliest literature on this was evidence linking the Dutch hunger winter to schizophrenia. This is quite interesting because schizophrenia is known to be very heritable. And yet it still seemed that it was more likely to be expressed if the mother had been subjected to famine. I think it's also an interesting outcome to look at, and I think it provided some credibility to the fetal origins hypothesis because it's severe and is very likely to be diagnosed correctly. So if somebody has schizophrenia, they probably will be diagnosed, they will show up in the data. Looking at something milder, there's a paper using Danish registry data where they have all the Danish twins, and they find a strong association between birth weight and ADHD, even in identical twins. So twins, when the next time you see a twin study, keep in mind that twins are always different, even if they're genetically the same, because they're almost always different birth weight. And that just has to do with where they got implanted in the womb and how much nutrition they got. So there can be quite large birth weight differences between twins, and those are associated with ADHD, and that the lighter twin is more likely to have this condition. Martin mentioned this paper already, and we saw his paper about the effect of stress. But I particularly like this one using Swedish registry data, which looks at the effect of a death of a close maternal relative during pregnancy. And the nice thing about it, there's other papers that have looked at that particular shock, but in this one, they realized that having a death in the family is not a random event. Now, I just showed you that mortality is higher in poorer places, so poor people are more likely to suffer from that kind of event. And so they compare women who had death of a relative during pregnancy to other women who had a death of a relative right after the pregnancy, right? So everybody here had the same shock. It's just whether it happened while the fetus was in utero or not. And then they can link that to future data, and they show that the children who had that shock are 25% more likely to be taking drugs for ADHD in childhood. And then those same children go on to be more likely to be using drugs for anxiety or depression in adulthood. So a nice thing here is making the connection between having these conditions that manifest in early childhood, like ADHD, and then having these conditions that we associate more with adults, like depression. Okay, so that's very sobering in the sense of thinking that you can affect somebody's mental health before they're even born. But it does raise the question, is there some kind of intervention that you could do in pregnancy to prevent future mental health problems? I mentioned this finding by Miller and Weary about the Kepler scores. And then I've done some work trying to look directly at certain interventions in the United States. This paper with Anna Chorney is looking at prenatal WIC participation. So WIC is another nutrition program which targets pregnant women. And in addition to offering nutrition and nutrition counseling, it also puts women in touch with medical services, and often this service is offered in a clinic. So women who are in this program are all eligible for Medicaid, but are more likely to get services than if they were not connected with this program. So we follow these children in South Carolina from birth to ages 6 to 11. And again, compare them to their own siblings. And we find that the children who were prenatally covered by WIC are less likely to have ADHD and also less likely to have other mental health conditions that are commonly related, measured in childhood. We also see that there's a bigger effect for Black children than for all children. And for ADHD, there's also a larger effect for low-income children, although that's not true for the other conditions. Okay, so you may have detected what seems like a logical inconsistency at this point, in the sense that I said, oh, there was this huge program. It had these really positive effects on children. These coverages should have improved mental health. But all we hear about these days is how child mental health is getting worse, right? So if we're doing all these great things, then why aren't we seeing an effect on reports about child mental health? And so here I want to raise a couple of issues which make it really hard to look at trends over time. One is that the diagnostic standards for many conditions are changing. Okay, so an example of that would be autism. So you hear a lot of discussion about how autism rates are skyrocketing, but you don't hear so much discussion of the fact that when they changed the diagnostic manual from DSM-4 to DSM-5, they took two categories which were separate, which was autism and Asperger's, and they combined them into one category, which is called the autism spectrum disorder. Right? And so instantly, if you're just counting that combined category as autism, you now have many more kids with autism, right? So that's just one example. A second thing that's going on, it can be precisely driven by the increase in insurance coverage. I think it was mentioned this morning that if you never go to the doctor, then you don't get diagnosed with things. So if I get insurance coverage and now I'm getting checkups, now I get screened, so now I may be diagnosed with something. So in general, you should expect that more access is going to lead to more screening, and it's going to lead to more cases. So I'm going to show you an example of that, where the switch from fee-for-service, basically the way that they compensated doctors, instead of paying them for each service, they gave them one capitated payment. Now, they were worried that that would cause doctors not to provide services, so they built in 2 checks on that. One was to pay doctors more if the child had a chronic condition, and the second one was to penalize doctors who were below average in terms of the screening that they were doing. Okay, so looking at the change in this, again, using data from South Carolina, in some work with Anna Chorney, we used the fact that different counties adopted this change at different times. And we look at 2 different things. One is an event study where we look before and after at all of the children. And the second is using an individual child fixed effect. We look at the same child over time, what happens to them when their doctor gets compensated in a different way. Okay, so this is the figure from the event study where I'm showing you on the top what's going on with well child screenings, and on the bottom what's going on with ADHD diagnosis. So you can see here the way that the ADHD diagnosis is following the screenings that children are getting. And then if we look at the same child, you can see that, and these children are all covered all the time. So they all have health insurance, and what's changing is just the compensation of the doctor. You see that they're getting a lot more services, including more well child visits. And then along with that, they also pick up more diagnoses. So I put here the mental health diagnoses in orange bars. So they're more likely to have ADHD, they're more likely to have depression, but they're also more likely to be diagnosed with physical health conditions like asthma. Right? So going to the doctor is hazardous to your health in the sense that you're going to end up with more diagnoses of things. One other example I want to highlight, and this has been something where there's a lot of concern, and justifiably so, are increasing trends in suicide among children. So this is using data for New Jersey. It's all suicide-related hospital visits, which are shown in blue. And then the black line is the suicide deaths, which is kind of noisy because there aren't a whole lot, fortunately. And then the brown is the suicide deaths in the whole Northeast region, which is a little bit less noisy. So what you can see is that these things kind of pull away, where I've put that line in 2016, and you see this increase in suicide-related visits. If you dig into that a little bit more, what you see is that that's mainly driven by this increase here, which is for a diagnosis called suicidal ideation, so thinking about suicide, as a secondary diagnosis. Okay? And then the red line is the actual self-injury or intentional self-harm, and you see there's no trend in that at all. So what's going on with this? It turns out there was a change in the way that doctors were instructed to fill in forms, and they were told that if somebody had a primary diagnosis of a mental health disorder, like a mood disorder, that they should put a secondary diagnosis of suicidal ideation if that was appropriate. And they could get, again, reimbursed more for doing a more thorough job of diagnosing people. Okay, so this is just the sort of thing to be aware of when you're looking at these trends over time in reported mental health disorders. It's just really difficult to know what's really happening with a lot of these things. Okay, so in my last 10 minutes, I want to talk a little bit about treatment. I showed you that when we were talking about insurance, it was convenient, at least for research, that there was so much variation across states. And in the same way, there's huge variation across areas in the types of treatments that are available in the US. So this map is showing prescriptions of antidepressant drugs by county per 1,000 persons 10 to 19 years old. And the legend here is kind of incredible in that the darkest red is saying there's 967 prescriptions per 1,000 teens in the darkest areas. And then in the lightest areas, there's 0. So there's really different propensity to prescribe to children, much more than we think can be driven by actual underlying differences. Okay, so in some recent work with Emily Cuddy, we've been looking at these variations in treatment. We select a sample of privately insured children. We try and pick up the first time that they had a mental health episode. The reason for that is because there's a lot of persistence in the way that people get treated over time. So the first time is sort of particularly important in establishing what kind of treatment you're going to get. And then we look at outcomes at 3 months, 12 months, and 24 months after the initial episode, using this geographical variation in the types of treatment that are available as an instrument. Okay, we look at depression, anxiety, adjustment disorders with features of depression and anxiety. And the reason for that is because those things are so closely related, which is shown in this figure. And we also consider whether the treatment that children are getting is broadly consistent with 2 types of guidelines or is inconsistent with either type of guideline. So we talk about FDA approved drugs. So those are drugs that are approved to give to children for particular mental health conditions. You might think, okay, well, everybody should always give FDA approved drugs. But the problem with that is that there are hardly any drugs that are tested specifically in children. And if they're not tested in children, then they can't be approved for children. So there's also what we call gray area prescribing, which is sanctioned by professional organizations, but not doesn't have FDA approval. And then there's a lot of prescribing, unfortunately, which doesn't follow even those kinds of guidelines. So we call that red flag prescribing. And this is just some examples of the types of organizations that make these guidelines, like the American Academy of Child and Adolescent Psychiatrists, American Academy of Family Physicians, and so on. In the sample, I just want to point out that about 75% of the kids get treated within 3 months of their initial diagnosis. 18% of children get some kind of medication, and that's what I'm going to focus on. Of these, 4% are getting the FDA-approved drugs, 10% are getting these drugs which are off-label but follow some professional guideline, and 4% are getting the red flag drugs. We look at self-harm, spending, and also utilization of different kinds of care. From here, you can see that these children who are prescribed the red flag drugs tend to have the worst outcomes for all of our outcomes and are also the most costly. Now, that could be because they're sicker or there's something else that's wrong with them. And so what we do is we use measures of the local area practice style and interact those with measures of severity, which gives us a lot of potential instruments. So then we use LASSO to select the potential predictors that do the best job of predicting treatment. So these 2 figures I'm going to show you just sort of summarize our estimates. And you could think of this being like a tree where people are either treated within 3 months, yes or no. Then if they're treated, they get some kind of drug, yes, no. But then you can see if they got a drug, their costs are actually a lot less than if they didn't, which implies that they're only getting therapy. However, that masks a huge amount of heterogeneity. If they're taking a red flag drug, they have high costs, especially compared to if they're taking one of these drugs that's recommended by a professional association. And also, if they're taking an FDA-approved drug, they have high costs. I think this is because if you take an FDA-approved drug, if your clinician was very strict about that, they would only have one drug to offer you for something like depression. If that didn't happen to work for you, then the only thing they could offer would be, you know, hospitalization, that sort of thing, which would be expensive. Looking at self-harm, it's a little bit different. If you skip down to the bottom here, you see that the red flag drug people have the highest probability of self-harm. And I should say this is after 2 years. People taking the gray area drugs are less likely to self-harm. And here, people taking the FDA-approved drugs have the lowest probability of self-harm. So you might think of those as being the most careful clinicians who are unwilling to offer other drugs, but maybe offer other types of supervision instead. So just to summarize here, we see most of the physicians are actually following a guideline, which is good. The clinicians, the children whose clinicians don't follow the guidelines have the worst outcomes in terms of everything. And so that, I think, raises an interesting question about, well, what can we do about it? Why are they prescribing these drugs, which are not recommended by anybody? Is it training? Is it marketing? We know that they're not directly profiting in any way from prescribing these drugs, so it isn't that. So that's an open question. So I just want to end by talking a little bit about a question that people often ask me, which is, okay, you've done all this work on children, so what's the best way to invest in children? And my answer to that is going to involve this paper by Nathaniel Hendren and Ben Sprungkaiser, where they looked at 133 different programs and tried to compare them all using the same metric. So the metric here is something they call the marginal value of public funds, and it's taking the estimates of the benefits of the program and comparing them to estimates of the cost. Now, in some of these cases, the government is actually getting back more than they're spending, and so that's the category right at the top here. So what I've circled is that these child programs tend to have very high marginal value of public funds relative to the programs for adults, where the ratio is clustered more around 1, right? So it's not saying that these aren't good programs. The value of the program is about the same as the cost. Maybe you like to redistribute to people with these particular problems, but there's kind of no comparison to the marginal value of public funds for children. So maybe the right question to ask isn't which child programs should we invest in, it's why aren't we investing more in children altogether when the returns are so high? Okay, so my overall conclusion then is that child health is one of the most important forms of human capital, affecting employment and wages, as well as long-term health outcomes. The interventions that we make in childhood really are investments. It's not just a rhetorical device to say so. And we need more research on this sort of missing middle period of adolescence, which is when a lot of these mental health problems are developing, and also specifically on promoting and treating child mental health. So I'll stop there. Thank you.
Okay, thanks so much for the super insightful talk. And yeah, well, I think we learned a lot, and in particular that we should invest more into children and their health. So now we have some time for discussion. Are there any questions from the audience or comments? Just 1 second, we have the microphone and use this.
Just okay, may I just ask one question to understand your first slides better, where you are telling that depending on exactly where in the US one is living, that the ratio of kids receiving Medicaid is up to 50% in some regions. Does it mean the up to 50% would not get any health insurance? Are the families so poor that the kids would not have health coverage? I think that's a little bit hard to understand from a European perspective.
Thank you for asking that. The other children almost all have private health insurance coverage. So almost all children are covered in the United States now, either through the public program or through a private program. The main exception to that is the treatment of immigrants. So, and that also depends on the state. So a lot of states have extended the public insurance to immigrant children, and then some states are not covering immigrant children. But the native-born children are almost all covered now.
Okay, thank you. Are there further questions? Maybe also from online? Up.
Yes, I personally have a question. Does the data already show how COVID-19 has affected child health? Is there already data? I mean, I imagine it would be, especially mental health, it would be like really affecting it. Do we have this data already?
Yeah, I think there's no doubt that COVID-19 had a bad effect on a lot of children's mental health, along with a lot of adults' mental health. I think an important question that we have to wait a little bit to answer is how long-lasting that will be. So, were the effects mainly because of missed school? Then do they get better when kids go back to school? Or are those kids going to be permanently disadvantaged? We know, again, in the United States, there were a lot of kids who went home from school and never came back. So it did have an effect on dropout rates. It also had an effect on college applications. There were a lot fewer kids who applied for college in that cohort. So those things presumably will have permanent effects going forward. But we don't know so much about the mental health.
Sorry, just on that note, we're currently working on the publication, the Social Insurance and the Medical University of Vienna on prescription, on the impact of COVID and the lockdowns on prescription data, mental health prescriptions in Austria. It's in revision right now, so hopefully we can answer that soon.
So there's some debate about the effects of social media on mental health of adolescents. What's your take on those recent data and studies?
Yeah, of course, that's very controversial, right? Because it seems like it can be very bad for some children, but it also seems to have positive effects on other children. So, what the overall effect is not entirely clear, I think. Are you referring to the Spanish study?
Referring to the Facebook study that I think recently came out.
Oh, the Facebook study, that's for college students though, right? So it's a little bit different group, but it does show. So they did an experiment where they basically compensated people for not using Facebook for some period of time, and then surveyed people in college, and the people who reported that they had stopped using Facebook felt better.
So, I mean, given this like stress in utero hypothesis and all the evidence that you've shown us, could you comment on what you believe, or maybe there's already evidence out there on the changes in abortion laws in the US and on the long-term effects on the children, maybe being born into more stressful situations than would be necessary?
Yeah, well, it's a very bad situation. I think it's very frightening, actually, having the government be so involved in people's medical care. And of course, you know, abortion access is important, but it's also affecting women with many other reproductive health issues. So we have already had reports about women almost bleeding to death because doctors felt that they couldn't do an abortion, even if it was, you know, no chance that the fetus would survive and the mother's in danger, and they still feel like they can't do anything or risk being in jail. So yeah, it's a terrible situation.
So we have time for one last question.
I was just curious that these kids have parents, and not all parents bring their kids to these medical services, right? Is there some idea about what share actually of the kids that need care do not get care?
So I think in the South Carolina data, what's probably more likely is that the doctors are just not doing a very good job diagnosing things. So we had a similar thing in the United States with vaccinations a while ago, where there were a lot of preschool age children who were not vaccinated. And when they did audit studies, they found that the doctors were not vaccinating them. And the reason they weren't was because they didn't keep very good medical records. So they didn't even know that they weren't vaccinating kids. So I think a similar thing could be going on here, where they're supposed to, so they get compensated a certain amount for doing a checkup. They're supposed to do a developmental screening, which might detect things like ADHD, but you know, they only have 5 minutes per child or something, so they don't do it. So it's hard to tell whether it's the parents or whether it's the medical providers in some of these instances.
Okay, sorry, maybe one final question. I had overlooked this, so if it's possible, we'll stop.
Yeah, my question is the interaction between mental health diagnosis among children and the parents. So the diagnoses also are on the rise for adults, right? And I was wondering if it's possible to somehow disentangle the effect on mental health of children from the treatment that they get, from the treatment effect that the parents get mental health treatments. Is there some evidence that there is like how strong the effect sizes, for instance, are, or how big they are?
Yeah, we've been trying to look at the spillover effects, actually. It's quite hard to convincingly identify, what's a spillover effect from one member of a family to another and what's some sort of common shock. So I can't say that I have a great answer to that. And I think another thing that's going on kind of in the background is as we talk more about mental health, it becomes less stigmatized, and then people are more willing to admit that they might have a problem. So that's sort of going on. And then also, as you have more treatments available, it makes more sense for people to come forward with a problem, right? So if you're in a society where mental health problems are really stigmatized and they can't really do anything for you anyway, then it's not unreasonable to just keep quiet about it. And then as that stigma goes away, and as you learn that other people are getting treated successfully, then you may be more open to being diagnosed yourself.
Okay, so thanks again so much. It was an honor and pleasure to have you here. And thanks everyone for attending and organizing this workshop. I think we had a great time and we're looking forward for the rest of the evening. Thank you very much.